Sorry about that. We're going to look at the new possibilities this year. How can we get out of this? Before looking at the types of treatment, I just want to remind you that we don't treat everybody. Somebody who just has microdimples shouldn't be operated on. Yes, they just need to be reassured, and there can be infection in two ways. So if you have acute abscess, in that case, the treatment will be an emergency incision. So you might want to train yourselves to carry out that kind of incision in your practice. Local anesthesia, it takes 5 minutes, and it is going to relieve the patients, and they will be very thankful. In case of the first abscess episode, you can just leave it at that, because 60% of patients don't have recurrence, and they will be cured. In case of recurrence, however, you want to conduct another incision for immediate relief, and then you are going to schedule surgery, just like in case of discharge. Chronic suppuration, that's the second manifestation. It's intermittent discharge in the microdimples or in secondary subcutaneous holes that you can see here. So the objective of surgery will be to eradicate the whole discharge, to minimize recurrence. So you want to be efficient, but also you want to have the simplest possible follow-up with a quick return to regular activity and the least possible impact on quality of life. So there is no consensual treatment so far, and we'll try to see how we can choose. For a long time, conventional treatment was that open sky resection with controlled healing. You have that kind of wound. It's not very painful, but it requires very long post-op care, daily or even twice daily, with a healing time that can go from 2 to 4 months on average. And we all have a few patients who stay with that for several months or even a year. Some surgeons conduct a resection with closing. I'm not going to go into the details. You have this midline, off midline, closing, plasty. And the idea is to decrease the healing time. So it's going to be 1 or 2 months of post-op care. And once again, it's a delayed return to normal activity. For the closing, in literature, you have more recurrence, and it's no longer recommended to have medial or midline closing, but it's recommended to go off midline. Here's a table here. I think if we offer a resection to a patient, you have to know what you do well. We used to do open sky resection. And you want to remember that these two techniques work well. We have long-time follow-up, which shows that there is very little recurrence. But the scars can be not very nice looking. The healing time is long. Post-op care is heavy. And so it has an impact on quality of life. This is why we've had those minimally invasive treatments. I'm going to skip on the many invasive techniques. Phenolization, you can't do this anymore in France because it's very toxic. The glue, it doesn't work. The pit picking is really, really old. Then you have sinusectomy, that like you remove the sinus, but this time you just remove the sinus and its extensions without resection around the sinus. So there's more recurrence than with resection. And for sinusotomy, sorry, that was sinusectomy. For sinusotomy, you open the skin and you scrape the cavity, and you have post-op care, which will last, which will be shorter. But there is daily post-op care that has to be implemented, so it's not something that we do very much. And now let me move on to the new minimally invasive techniques. Let's start with the endoscopic treatment. You have a lot of gastroenterologists in the room or from a distance. We do use a lot of endoscopes, and this time it's a fistuloscope. It's a rigid endoscope that you insert in the dimples. You can enlarge it to have access to the cavity, and you have 2 stages here. The first stage is diagnosis. You identify the root, and then therapeutic phase. When you clean up the cavity, you remove all the granulation tissue, all or hair or whatever, and then you cauterize this and the extensions of the cyst. It's a technique that's been validated. I think the first articles were published in 2014. The cure rate is higher than 90%, and it increases if you do it a second time. Several studies have compared this treatment with a surgical technique, but and they don't show any difference. But there is not. It's not significantly. It's not significant actually because it was too small a sample. Now, endoscope treatment is pretty long because the time of procedure is about 40 minutes to 60 minutes. You have to be trained for that. You might go on the wrong route because it's a very rigid endoscope, so you have to be very careful. And accessibility also is limited by the availability of the piece of equipment and the cost of the equipment. So in France, it didn't work so much as this second treatment, which is laser. You must have heard about it. It's called SILAC or SILAT. It's what we do the most here in Saint-Joseph. So you resect the microdimples and the secondary cavities with a tool. You have access to the cavity, and you are going to operate curettage, but blindly this time. So you irrigate, and then you place the laser fiber in the cavity through all the orifices, and you remove the probe. And then you are going to deliver energy so that there will be a fibrosing inflammatory reaction, and the root and the orifices will then be closed. It's radial emission probe, which sends waves on 360 degrees with a tissue penetration of about 2 or 3 millimeters. So we avoid diffusion to the adjacent tissues, and there's no consensual setting. Usually we go for 10 watts. But I'm not going to go into the debates of this because we are not really sure what should be done. It works quite well. We've got a lot of data for laser. It's a low level of evidence, of course, in those studies, but we have a cohort of about 1,000 patients. The success rate is almost 90%, with a median follow-up of 12 months. So that's the caveat. Recurrence 4%. 10% of complications, which were benign infection, hematomas that did not need us to operate on the patient. Monocentric study with a success rate of about 80%. It's a study that we conducted here with a very, very simple follow-up. The median healing time is 20 days, so we see the patients after 3 weeks, and the healing is completely done. Post-op complications, almost none. Return to regular activities 3 days, plus or minus 2 days, so no need to be away from work. And the satisfaction rate of the patients is even higher than the efficacy rate. So, some patients have had a failure of the procedure, and they ask us to do a laser again because they don't want to have the big scar. So we had a paradigm shift, you see. In 2017, it was mostly excision, and now they want to go for laser. The patients would prefer laser, so that's what we do the most. A word about radio frequency. It's exactly the same principle as laser treatment. We used an RF probe. It's electromagnetic waves, very high frequency, like microwave if you wish. We have several sizes of fibers. The power is set at 25 watts, and the tissue penetration is the same as for laser. And the concept is exactly the same. It works exactly in the same way. Very easy to do. You don't have a learning curve as you have for endoscope treatment. We have much less data in literature. This is a pilot study carried out by Nadia Fatala. It's a prospective pilot study with a 6 months follow-up. We had 44 patients. 38% of them had already had surgery. The average duration was 12 minutes. No secondary operation. Efficiency was at 77%, recurrence 9%, and the satisfaction rate was around 75%. Now, this is not something that we do very much of in France, or endoscope treatment, I mean, because it's not reimbursed by the Social Security, and also because of the length of the procedure. Laser or RF lasts about 10 to 15 minutes, so endoscope is much longer. I'm not going to tell you about the other treatments. I'd like to tell you about a few adjuvant treatments, especially definitive depilation, by laser. It's used by dermatologists to remove the hair, because it's the pilonidal sinus has to do with the follicles, hair follicles, so it's good to remove the hair. We have a certain number of studies which show a different range of results, but it seems that the recurrence is not so frequent. What's interesting is to look at the comparative studies, and there is a decrease in the rate of recurrence when the patients have been laser depilated. But final depilation does better than the other treatments, especially shaving. There was a study published last year which shows that there was minus 23% recurrence after 1 year in the laser depilation group versus the shaving group. Of course, it's expensive. It's not reimbursed by the Social Security. And what's the time frame? Because you cannot have laser depilation in case of an abscess, because it takes several sessions. So it has to be planned in advance, but it can be an interesting thing. And I have to tell you a few words about cell therapies, autologous stem cells. It's still being researched for platelet-rich plasma. We have a little bit more information. You have here 8 randomized controlled trials plus 1 prospective cohort study that showed that it could help reduce the pain and the side effects and a faster healing. But it's not incredible. It reduced the healing time by a few weeks. But it's interesting. Maybe something to consider. So here's the algorithm. If there is an acute abscess, you need to perform incision urgently. And I really recommend that you do this in your consultation, in your practice, rather than going to the operating room, because it relieves the patients and you save time, and the patients are very grateful, and in 60% of cases there will be no recurrence. If there is recurrence, another incision, and then you suggest surgery, but not urgent. And then you have to mention the 2 possibilities to the patient so that they can decide. You have conventional surgery that includes excision plus sinusotomy, which I don't consider to be different from surgery. And we have a lot of follow-up on these techniques with a low level of recurrence, but you have more recent minimally invasive techniques which seem to have the same level of efficiency, but we don't have the same level of follow-up. But the post-op is much lighter. In case of a recurrence, well, then you go back to the same situation. You can do everything. After an excision, you can go back to an excision or to laser. After laser, you can go to excision or go back to laser. You can do anything you like. I think that for recurrent patients, you have to ask yourselves the question of maybe laser depilation, not reimbursed by the Social Security, and you have to consider maybe cell therapy. And the conclusion of this presentation is that, just like all the other talks, the preferred treatment is really based on a shared decision with the patient, who needs to have all the required information before they can make a decision with you and your advice, of course. Do we have questions? Thank you. Sometimes there seems to be a long time before recurrence. So what, I mean, if there's a 5-year lapse between the 2 recurrences, what do you think? It's as if you were starting from scratch? Well, I think an abscess has a positive evolution very quickly. So if the patient has an abscess again 2 months later, while he was asymptomatic during a certain period of time, I consider that it's recurrence. Either the abscess is cured and then there's recurrence, or it stays there and it's chronic, but in all cases it's going to be an indication for surgery. If the patient comes and you excise it and then it goes better, it heals well, and you have the same collection, and then it comes back, in that case it's the same abscess and you have to re-excise it again in order to optimize the drainage. Was that clear? Now, during the recurrence, I've been in practice for 47 years. Well, not me. And I receive cysts which have recurred. And I found 7 to 8 minor forms of spina bifida. And so you need to think about this when there's recurrence. Oh yes, absolutely. We don't see that a lot, but you did operate a lot. But it's rare, but we need to think about that. It's a possibility. Yes, because you operate on the person and then you operate again, but there's a bone problem. So that's what you maybe need to think about. Good morning. Thank you for this talk. I'd like to ask, when you drain the abscess, do you actually leave a drain? When we make an incision? No, not at all. You just take your cold knife, you put it in, and that's the only thing you do. Because I usually leave a drain on for 3 days. Yes, I know, but you're a visceral surgeon. We are GEs. And I can tell you that our patients are doing fine. It really takes 5 minutes, literally, and there is no care. No, after that local anesthesia incision, we ask them to massage around the wound to let the pus out. We do a cross-shaped incision, or very broad incision anyway, and we just use a little absorbing dressing, and we don't leave a dressing. I know it's always a drain. Sorry, I know it's always shocking for surgeons. Thank you, Deborah.